brought to you by some of our great friends up north at the University of British Columbia and some other friends distributed around the world, led by Dr. Tal Jarus, who's professor of occupational therapy with the Faculty of Medicine at the University of British Columbia. Off to you now.
Thank you. Good morning, everyone. I'm really glad to be here in a space full of people who know firsthand what it means to navigate health professions as a disabled person or to work alongside those who do. My name is Tal. I'm a white woman with salt and pepper colored hair, maybe more salt these days than pepper. I wear glasses, green shirt with a black vest on it, and I'm joining you from the traditional ancestral and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations on Turtle Island, or what you might know as Vancouver, Canada. I'm a disabled OT researcher and educator. I believe that in this space, we do not need to provide the rationale for our studies looking at barriers experienced by disabled health profession students and practitioners, and why it is important to increase diversity among health professions. Not only does the mere presence of disabled clinicians increase cultural safety in healthcare, but disabled clinicians also bring unique skills based on their experiential knowledge, skills that are beneficial for their clients, along with strategies that they acquire and a deep embodied understanding of living with a disability in an ableist world. And I think some of the presentations earlier today demonstrated how this diversity might be impactful. In the past few years, we conducted many studies exploring the experiences of health professions, disabled students, and practitioners across Canada. Overwhelmingly, the main overarching theme was participants' compromised sense of legitimacy and belonging as health providers. Participants described tensions within health education and practice between the commitment to inclusion and the day-to-day realities experienced by disabled participants. We identified 6 distinct but related factors underlying those tensions, and I will just start to share my slides so you can see those. I press share. Okay, can you see that? Perfect. So the image shows a fan shaped figure that opens upwards like a sunrise. At the center is a dark circled labeled factors compromising legitimacy and belonging. Radiating around outward from the center are 6 slices, each representing one factor. The inner ring of slice contains an icon for each factor, and the outer ring displays the number and label of each factor. The outmost section extending beyond the fan lists the sub-themes associated with each factor. The 6 factors are, first, validity and transparency of competency evaluation. Second, the social and physical context of practice and education. Third is the system integration of possibilities for inclusion. Fourth is reconciling personal and professional boundaries. Fifth is vulnerability to undermining interprofessional relationships with authority figures. And the last one is dynamic person level factors. While I won't go into depth on each of these factors right now, they will thread through today's presentations, each of which zooms into a different part of this picture. And if you'd like to dive deeper, the full study was published in Medical Education. It's open access, so you can read it freely, and we are happy to send you a copy directly if you reach out to us. So first, I would like to invite Laura, who is asking, are health professions culturally safer for students and clinicians with disabilities?
Thanks, Tal. All right, I'm excited to be with you. I am also joining here on Turtle Island on Musqueam territory. And I am a white settler, a Dutch settler to WSÁNEĆ territory originally, and I'm a disabled occupational therapist and educator, and I'm a tonta, an auntie, and a sister, and a friend, and an activist or a troublemaker sometimes. And on this side, there are a bunch of photos representing various relationships in my life. And I want to acknowledge that any work that I do is very much done in relation, and that's an important part of my work. I will describe myself a bit. I am wearing orange earrings, beaded, by an Indigenous artist, and an orange jacket. There's an orange couch behind me. You're getting a theme. To me, the color orange represents resisting injustice. And that is what we hope to be doing in the work that we do through the Inclusive Campus Project. All right, so I want you to keep in mind throughout this presentation what makes you feel safe in your healthcare experiences. I want to also introduce some concepts. You might already be familiar with the term cultural competence. There have been a few terms, and the understandings that we have really evolved. And cultural competence is most often used to describe the healthcare provider. It really focuses on the knowledge and the awareness and the skills of the practitioner. Now we have another concept that has been introduced, and this comes from Indigenous community. And this is really a paradigm shift. This is cultural safety, and it goes beyond knowledge and really redefines that relationship and no longer focuses on what are the skills of the practitioner, but rather it focuses on the relationship and redefines the relationship so that responsibility and power lie with the patient as well. So there are a few pillars in cultural safety. It really centers on sharing, so shared respect and meaning and knowledge and experience. It's about learning together with dignity. And it calls practitioners to understand the bicultural nature of that patient practitioner relationship. It begins with ourselves as the practitioner and our own identities and the imprinted stereotypes that we have. And then it goes to seeking to understand social determinants of health as well. And cultural safety, grounded in Indigenous community, has also been applied to other communities, including disability. And particularly, this is something that we are discussing today, is thinking about cultural safety in the context of disability culture. So one of the great pillars of cultural safety is the idea of representation. So representation of diverse backgrounds within healthcare professions is really the only way to assure that different cultural backgrounds are embedded within healthcare practices and to balance those power hierarchies between service providers and service users. So it raises the importance of representation as a way to balance power. And it is really a must if we're going to impact decision making and resource allocation. So, to allow representation in healthcare programs must be accessible and inclusive for people from diverse backgrounds, including disabled folks. So we wondered, how can healthcare cultures be safer for people with disabilities or disabled people? Healthcare cultures, as you all well know, are often competitive and stressful, and they usually encourage protocols and they distinguish between the healthy and strong and capable service providers and the service users that are ill and weak and incapable and in need. Disability culture has a lot of contrasts with that highly competitive and productivity focused and independence-focused healthcare culture. So in disability culture, we celebrate diversity and including disabled identities as part of that. We want to recognize the unique contributions of disabled folks to community, not in spite of, but sometimes because of our disability experiences. And we really embrace varying perspectives, and we also embrace the idea of interdependence. So this idea we're talking about of taking cultural safety and disability culture and thinking about our health professions and health professions education is something that has emerged as we've done hundreds of interviews with healthcare providers and students with disabilities. And a couple of pieces I wanted to share from what they've said. One is Kia's student saying there's this silence. There's this silence around it, and nobody talks about it. I think we need to explain what disability means or what disability looks like for people to actually understand what it is. And a clinician said, I think the more we educate everybody going into the healthcare field, the more that those general systems will be hospitable so that other people might be struggling, that supported and feel like reaching out is not a sign of weakness. So these speak to the need to shift healthcare cultural. So really, we are making a plug for expanding the idea of cultural safety to explore opportunities where we can increase equity for disabled folks in health professions. And we also know that one of the pillars of cultural safety is representation at all levels of an organization, and in this case, at all levels of healthcare and healthcare education. So representation is necessary for cultural safety. It's not optional. If disabled people are excluded from the professions, then cultural safety cannot happen. And we also know that there are tensions between healthcare culture and disability culture, some of which I've brought up, but I'm sure that you can identify a lot more. So some questions that I'm going to invite you to be thinking about is how can these tensions be resolved? Can they? How do we do that? And how can health professions education and practice feel safer for us as disabled folks to allow participation and representation and prevent cultural destructiveness? And what are the tensions and the advantages of expanding and borrowing the term cultural safety to disability studies as a term and a concept that is grounded in Indigenous community? And how can we perhaps develop this concept in order to benefit everyone in the health professions community? All right. So I invite you to think back to what makes you feel safe when you're receiving healthcare services. I mean, consider if perhaps something about the identity of a healthcare professional might also be part of that. All right, I am going to pass it back to Tal to move it on to our next speaker, and I look forward to engaging in discussion with you a little bit later.
Thank you, Laura. So I'm going to invite Natasha, who is going to explore the shifting discourse on ableism throughout the perspective of disabled OT advocates. And
Thank you, Tal.
I'm going
Okay.
to allow you to control. Can you?
Yep.
Perfect.
Yes, thank you. Okay, good morning, everyone. My name is Natasha Robillard. I am honored to present my research at this conference, which I am doing with the support of Tal and Laura. So about me, I recently graduated from OT school and I am a new licensed clinician. I am white. I use she, her pronouns, and I'm presenting from my home office in Montreal, Canada. I am wearing a multicolored turtleneck and have my hair up in a ponytail, and I'm wearing silver earrings. I identify as someone living with an invisible, episodic, and long-term health condition. I choose to mostly identify using person-first language based on how I relate to my disability. However, I deeply acknowledge and respect the different ways people choose to identify. So my presentation is providing a more focused look into the profession of occupational therapy and is called Reimagining Toward Anti-Ableist OT. Going back to the fan of conditions that Tal introduced at the beginning, my presentation would relate more to what I feel is number 3, so integration of inclusive practices specific to OT here. So the rationale and background, the focus of my study specifically looks at how discourse around ableism in occupational therapy has shifted over the last 25 years through perspectives of key disabled OT advocates and researchers. As we look ahead to building a more anti-ableist OT profession, it helps to look at where we are and where we are coming from. So currently, occupational therapy often operates within what we can call a sort of OT paradox. This means that generally, occupational therapy prides itself and is often recognized for having a more holistic, collaborative relationship focus and client-centered approach. However, like many health professions, OT's view of disability traditionally applies biomedical models of health, where disability still tends to be seen as an individual deficit or impairment needing to be fixed. So the dualistic nature of the profession's holistic social versus its medical approaches exposes this disconnect between occupational therapy's principles and ableist realities. And this disconnect has real world consequences. So while we see increased participation of disabled students in education, this does not necessarily translate to the workforce. In Canada, for instance, based on a 2010 federal report, it showed that only 4.8% of healthcare workers identified as disabled, one of the lowest representations across all sectors. While this data is a bit outdated, the lived reality is still similar across many healthcare professions today, including occupational therapy. So this highlights a harsh truth that access to education does not guarantee inclusion in professional practice. So the specific aim of this study is to explore the perspectives of key advocates on their experience of ableism and its shifts throughout their career, to understand and reflect on the barriers and facilitators that enabled shifts to occur. So the methodology used is a qualitative interpretive description methodology through a lens informed by critical disability theory. Interviews have been underway with 5 participants who are all based in Canada and specifically chosen for their unique work and research history. The inclusion criteria focuses on participants who have lived experience of disability, are licensed clinicians, and have been recognized for the work that they do in advocating against ableism in OT or healthcare. Semi-structured interviews have been taking place, averaging approximately 5 hours per participant. Once data from the interviews will be fully analyzed, a collective reflection meeting will also be organized with all participants as a way of having their unique knowledge and expertise guide the study. So in terms of general findings that are being heard or are coming out of the interviews, One major shift that has happened on a larger societal scale that is trickling down into OT has been the naming of ableism. As one participant noted, once something is named, it can be changed. So this naming creates more legitimacy and room for critique. In addition, when looking at published research on ableism between 2000 and 2025, there is a massive spike in the last 5 years. So we went from 1 to 2 publications per 5-year block to a significant increase recently. Whoop. So 3 key themes are emerging regarding the current landscape. First, OT tends to react to social shifts rather than lead them. So we follow movements once they gain traction elsewhere. Second, there is a significant cost to speaking up. Disabled OTs disproportionately bear the professional risk and emotional labor of pointing out ableism. Third, we also see a divide between academia and clinical reality. While anti-ableist concepts are gaining ground within the research realm, we are seeing minimal change in actual clinical settings. Some of the reflections heard during the interviews point to education serving as a lever for transformation. However, that involves addressing the hierarchy of knowledge and openness towards self-reflection, especially in occupational therapy. So some discourses are currently critiquing OT for failing to examine its core ableist values and history, or failing to include disability scholarship. So in terms of the barrier, reflexivity often requires being unsettled, yet there is the often heard defensive refrain in OT where it's like, of course we're not ableist, we're OTs. Also, OT often speaks about disability from a sort of expert stance rather than being disability-led. So we need to shift towards centering lived experience as equal to professional expertise. And whoops. So here is a meme in relation to the OT quote unquote expert perspective. So it reads, decided to speak for and over disabled people instead of actually asking what we want and how we feel. So sometimes humor helps put things into perspectives. In terms of what the current interviews seem to point out is that the profession is in a sort of pre-takeoff moment. So while critical disability and anti-ableism concepts are finally emerging in occupational therapy, the profession remains largely reactive. Change is currently fragile and is often contested, but momentum is building. We have not yet achieved the structural transformation required to be a truly anti-ableist profession, but the movement is following a recognizable social change trajectory. We are on the cusp, but the heavy lifting of systemic change is still ahead. The paradigm shift matrix. So if we are looking at the current state of the profession, it centers around a mostly biomedical approach to OT, relies on expert professional knowledge, avoids discomfort and deep reflexivity, and speaks mostly about disability. But if the paradigm shifted towards a more anti-ableist OT, the profession would integrate critical disability theory into its foundations, practice epistemic humility, embrace critical reflexivity, and be guided by disability leadership and lived experience. To move forward, we propose 4 initial recommendations for change, which of course are to be confirmed through data analysis. So the first being curricular reform, to move beyond a biomedical model and integrate more fully critical disability theory into how we train future OTs. In terms of recruitment, to actively recruit students and faculty with lived experience of disability, or to recruit students and faculty that have already been exposed to anti-oppressive frameworks. 3, epistemic humility, that we must value lived experience as equal to, if not more, vital than clinical expertise, especially in a field like occupational therapy. And then 4th, reflexivity. That reflexivity isn't just a one-time thing, but that we need to institutionalize ongoing bias training across the entire career span of an occupational therapist. And then in conclusion, essentially, to move towards true occupational justice, the profession must acknowledge its ableist history, embrace discomfort by engaging in critical reflection, actively dismantle ableist structures that shape practice, move away from this expert stance, and center disabled knowledge and expertise. Of course, these steps go hand in hand when moving towards a more diverse and culturally safe OT profession. Thank you so much.
Great. Thank you. So next we're going to next we're going to have Stacy, who is going to talk about neurodiversity. Let me just share her slides now.
And introduce myself while you're
Go ahead. Yeah.
doing what you do, Tal. Thank you so much. I have a prop. Here we go. This goes with my presentation, okay? You'll understand soon. All right, so I'm Dr. Stacy Greeter. I'm a child, adolescent, and adult psychiatrist. And my special interest is incorporating fun fantasy themes into presentations about everything psychiatry. So I myself am autistic and ADHD, and have multiple chronic illnesses, and I'm really excited to present. I am a white, blue-eyed person wearing a fluffy headband with little monster horns and eyeballs. And my talk today is how we show up, is about how we show up as advocates. Specifically, my experience has been advocating for more neurodiversity affirming medical field, to both better support our neurodivergent patients and better support fellow neurodivergent clinicians. Slides. Where are the slides up yet? And I just can't see them, or
Can everyone see the slides?
I can't see any slides.
No.
Oh, you can't see the slides?
Mm-mm.
Oh, I didn't share them. I thought
It's
I shared them.
okay.
There you go.
Stand by.
Share.
Hi, Dr. Stacy Greeter. I'm back. Apparently we had an internet glitch. Thank you, everyone. So I was introducing myself. I'm autistic and ADHD. I'm in Sarasota, Florida, and I'm licensed to see patients in Colorado, Washington, and Florida. Thank you so much for joining and for your patience with our technical issues this morning. So, the monster theme of this presentation, because often we think that people whose ideas differ from our own we often are polarized and may demonize those ideas. So I have, my presentation is full of friendly monsters, and how do we show up effectively as advocates to help people take in our ideas instead of reacting defensively. Specifically, my experience is with advocating in the neurodiversity movement for more neurodiversity affirming and less ableist medical field for both our patients and for our fellow colleagues. All right. Am I able to move it? Oh, there you go. I'm moving the slides. Sorry. Sorry for the clumsiness here, everyone. Clumsy monster that I am. It takes an average of 17 years for new medical evidence to change prevailing medical practice. So how long will it take for our healthcare system entrenched in a deficit-based model to really move from pathologizing perspectives on neurodivergent people to less pathologizing perspectives? How do we get there into deeper understanding, which then translates to healthier clinicians and better care for autistic people? Now, first, we need to define what does neurodiversity affirming mean? What is that? And there's a lot of confusion here. Essentially, neurodiversity affirming means that we recognize that there are various different types of brains, and they have both strengths and vulnerabilities. That the ideal is not to be the closest approximation of a neurotypical or average brain, but to be your most authentic, meaningful, functional self. So it centers lived experience and autonomy. What it does not mean, it doesn't mean that lived experience is the only valid form of understanding autism and other forms of neurodivergence. It doesn't mean we only talk about the good parts or the strengths of being neurodivergent. It also doesn't mean that neurodivergent people need no medical treatment. I gave a presentation at this conference last year, and it was on helping our residency, medical school, and other training programs to better serve the needs of neurodivergent trainees. And I actually consulted with a colleague with much more experience than me doing this advocacy work because I wanted to do a good job. And what she told me really stuck with me. She told me it's far easier to make things worse for autistic doctors and set us backwards than to move things forward. And she actually advised me against presenting at all, which I know may surprise some people. Clearly, I did not take that advice and still presented, but her concerns were valid. Her concerns were, what if I shared about my struggles during residency as an autistic clinician, and that made audience members think autistic doctors aren't good doctors? What if any criticism I had of our current medical training program and the medical system would make the system reject us even further defensively? And also having a psychiatry resident in training present openly autistic could be risky for their future career. Though obviously if you're doing a presentation about trainees, it's good to have the lived perspective of a current trainee. And so it made me think a lot about how I show up as an advocate for other medical professionals, especially, and how can I engage people without eliciting a defensive response or turning people off. At the same time, my colleagues presenting with me, when I said, hey, we need to make sure that we are engaging people positively, said, you know, if we completely sanitize the pain of our experience during training as autistic clinicians, that's not going to be showing up authentically either. So there's a balancing act here, really. And then, of course, thinking about all this made me go into an autistic deep dive into how do minds change and what are the most effective social justice movements? What have they done that works and doesn't work? So as a child, I felt pretty unseen and misunderstood and alone. I didn't feel like I had a voice. And this same wounded child in me is a lot of what drives me to speak up. I need to speak out for other misunderstood and unseen people, especially children. What do you know, became a child psychiatrist. You could see that one coming. So inside every advocate is a wound. And this same passion that like inspires us in the wound, that inspires us, is both an asset and a liability to our cause. The advocacy work itself is both very healing because we now can have a voice and do some good and feel empowerment, and hurtful because of the responses we get. So here's an example. At the very bottom there is a little snippet of feedback that I screenshot after a presentation I gave on autism for a children's hospital. It says, you know, it's difficult for me to consider or believe this speaker as autistic at all. And this is pretty common feedback that I get. There's no way you could be autistic. We've been doing it this way for over 50 years. And how old are you even? That's not the gold standard. Where did you do your training? And that can elicit a lot of rejection sensitivity and a lot of pain, because we are showing up sharing an extremely vulnerable part of ourselves, and how important this is to us also makes it a liability in how we can withstand the onslaught of other people rejecting what we're advocating for. So why is it so hard to change people's minds? There's a really good book, How Minds Change. The author is McRaney. If you want to explore this in a little more depth, by the way. But there's some really core, interesting issues here. So subjective viewpoints feel objective. You probably notice in training all the time, you are taught like, this is how it is. And when in fact, medical science is an ever evolving, ever changing, dynamic thing. Social death is scarier than physical death. What do we mean by that? Okay, so our beliefs are cemented by being part of a group. And to hold a belief that is different from our group's belief puts us at risk of rejection or so-called social death. So let's say I'm a child psychiatrist. I'm advocating to other child psychiatrists that autism has both strengths and vulnerabilities and is not, in fact, a disorder to be eradicated. And I risk losing credibility and membership in my field of child psychiatrist when that is not the prevailing belief. And this kind of relates to evolutionary psychology some. Like, we need to really understand the power of this. Because back in the day, you're a caveman, you fall down, you break your femur. If you happen to be an unpopular person who held beliefs and advocated for stuff that the group didn't like, you will die. No one's taking care of your broken femur. So our brain actually interprets rejection from our tribe as deadly. And then there's just facing the discomfort that we've been wrong. I don't think that we make it safe enough during medical training at all to be wrong and make mistakes and correct ourselves. And that's very sad, because a non-defensive, curious, open place is so key to practicing good medicine and helping us change our ideas and helping us evolve as medicine evolves. When I accepted that I had been wrong in some of my beliefs about, say, autistic people lacking theory of mind, which I was taught in residency, I had to face that I had misdiagnosed some of my patients who are autistic. I had to face that I had been wrong about my own diagnosis, and that was really uncomfortable for me. So that's another reason it's hard to change. Let's dive in more into how subjectivity feels like objectivity. So there's this like rider and elephant metaphor here, okay? We think that we're making a logical decision, but what actually happens, this is from social psychologist Jonathan Haidt's theory. What happens is our emotional intuition, the elephant here, nudges us in a certain direction. Then we make post hoc rationalizations to explain why we went in that direction. So it seems like we're being objective when we're often not. And what is it hardest to be objective about, and what is actually decision making that applies to values and beliefs? So our natural urge in trying to change people's mind is to give them lots and lots of facts, because we think, obviously, if they had all the facts, then they would think like we do, because we think we're being objective, and it's just an issue of missing information. What actually we social psychologists find works better is stories. Instead of info dumping, which has its place, of course, we tell stories that resonate with the elephant, the emotional intuition parts of us. We also help people understand why they think the way they think. This is called mentalization, when people have to think about their own thought process and really be curious, and help them be curious about how they came to hold their beliefs. So, what were you taught in residency about autistic people lacking empathy? Oh gosh, let me tell you a story about how I was totally wrong about that and the thought process I went through. As opposed to, you are wrong. We need to really respect what people may risk losing by changing their minds. So, they believe that such and such is the gold standard of treatment. And then they have to grapple with the fact that now there's a new standard, which means that they have not been offering as good a care as they could have been offering. And they may also risk, like, if they've been aligned with the pathologizing model of autism, they may risk like so much in terms of how they've been teaching their patients, how they've even thought about themselves. People may want to believe that DSM-5 is 100% accurate, even though it's called DSM-5. There's been 5 iterations of it, because it's really scary to think this is a socially constructed, highly fallible document that's going to look completely different in 20 years. So if I change my beliefs from what I was taught in residency about neurodivergence, I will be judged by other psychiatrists, maybe as a bad psychiatrist who sees autism everywhere, or doesn't really understand what autism is, or it's just kind of like nutty part of the social justice movement, right? So many things. There's a lot of risk here. The degree to which people feel certain about a particular belief, even when confronted with contradictory data, is directly proportional to the degree to which they identify as belonging to a particular group of people who holds that same belief. Sorry, I'm having trouble like keeping my slides on the same slide.
Stacy, you have one more
Yes.
minute.
Oh, okay. All right. So I'm going to kind of hurry up here a little bit. Thank you for the time. It's a lot. So what works? Eliciting self-reflection, evoking from the other person their reasons and for staying with the belief, and evoking more than you input. People are more likely to be persuaded by what they hear themselves say, not what other people say to them. Cultivating openness, curiosity, and welcoming disagreement. Becoming a, quote, amygdala whisperer. So you're not setting off defensive tripwires in the other person's brain. There's actually an fMRI study where they put people in the scanner and then they presented them with information that was disproving their political beliefs. And the participants who had less amygdala activation were able to change their beliefs more readily. So we want to avoid defensiveness, threat, and judgment. Listening more than we speak and sharing stories. I think that there's a lot I could say about our training and education system, but one thing I hope is that we can create a training system in which it's safer to be wrong, in which we recognize the subjectivity of our clinical practice and how we view neurodivergence. It's understandable that people want safe spaces where they are with people who agree with them and who hold a certain viewpoint about neurodivergence, neurodiversity affirming spaces. However, for someone to change their beliefs in line with your group, they must feel welcome, safe, and respected in your group. So we need to try not to demonize people who hold beliefs that are different from our own. And while spaces of groups of people who share our beliefs can be nice for when we want to feel seen and understood, advocacy work happens through actively engaging with people who share beliefs that are not the same as ours. I also think that we really need to do a lot to bridge the gap between academic institutions, clinical practice, and lived experience. And we do this through gaining allies rather than demonizing people who are different. One issue I've come across in the neurodiversity movement is that like I made an autism symposium centering lived experience, and there is some debate whether people who are not autistic themselves should be giving presentations. I strongly believed that we should be inviting all neurotypes to be presenting in the symposium because we need allies. And and not only that, lived experience is not the only valid form of understanding a particular condition. So mentorship and teaching people how to advocate effectively is really important too. If you want a longer video on this, I'll put my YouTube channel in here because I went really fast and probably went over time. You can
Thank you
go
very
check
much.
it out.
Thank you very much. We're going now to our last
Okay. Hello. So I'll start presenting myself while Tal is sharing the presentation. Thank you, Stacy. So hello, good morning. I'm very honored to be here today. Thank you for inviting us. And I'm joining you from Israel, so it's nighttime here. My name is Yael. I'm a white woman, long brown hair, glasses, and I'm wearing black shirt. I am a clinical psychologist with the lived experience of a disability and an associate professor at the University of Haifa. So the title of this talk is Epistemic Justice in Action, Learning from Disabled Healthcare Students and Professionals. So Tal, can I move
go ahead.
the slides or?
Yeah, you can do.
Okay, I don't see where.
There's an arrow at the bottom left side of the slide. You just, yeah.
Oh, okay. Thank you. Okay, now I see it. Thank you so much. Just a sec. Okay. Right, I need to move it. Right. How can I move it back? Okay, Tal, maybe you'll control it? Okay, thank you. So today I want to share findings from a study we published this year in Nurse Education Today. What makes this research different is that we didn't study disabled health students and professionals from the outside. We actually asked them directly, what do you know? What advice would you give? And their answers became the knowledge at the heart of this work. So there is a critical gap in healthcare. We all know that disabled individuals are consistently underrepresented in health professions, and not because of lack of capability, but because of structural inflexibility, high demands, and persistent stigma. The concept we anchor this work to is epistemic injustice. When institutional structures prevent disabled professionals from contributing their specialized experiential knowledge, the entire field suffers. Their wisdom on navigating disability, on what disabled patients actually need, is a form of expertise that is too often silenced. And the consequences of that is beyond equity or inequity. Research shows that the presence of disabled health professionals actually improves patient outcomes and experiences. So it's not just about fairness, it's also about the quality of care that we deliver. So I'll show you the study. I will report on the data that focus on what advice our participants would like to pass forward. We conducted 124 interviews with 56 disabled students and professionals in 5 professions: medicine, nursing, occupational therapy, social work, and physiotherapy. Data were analyzed using reflexive thematic analysis. And what emerged are 2 clear categories of advice. One for individuals navigating the system, and one for non-disabled allies building a better one. I'll tell you that when I worked on this presentation, I felt that this advice resonated with me so much, especially in the point of my disability journey. And I hope it will resonate with you. I'll be curious to hear. So the first path belongs to disabled students and professionals themselves. It is grounded in lived experience, in personal agency, strategic decision-making, and resilience. So the disclosure dilemma, a calculated decision. One of the most nuanced themes was disclosure. Our participants were clear. Disclosure is not a single event. It is an active, intentional, ongoing process, one that requires weighing benefits like accommodations and solidarity against real risks like stigma or being delegitimized. Students reported more hesitancy than professionals, given the power imbalances in education environments. So participants offered very concrete advice. Disclose early to supervisors when accommodations are needed, but build trust gradually with your peers. And when you disclose, frame it around the solution, what you need to succeed, not just around the difficulties. Disclosure can also be subtle. For instance, one professional with hearing loss would casually say to a colleague, "If I walk on this side of you, I can hear you better." Just simple and practical. Our participants talked about when to disclose, what to disclose, and how to disclose. The next advice is beyond disclosure. Participants emphasized 3 things. One is know yourself deeply. Know your limits, know your strength. The second is reframe disability as an asset in care. Like Valerie, a student, said that she would probably have more in common with some of her patients than her non-disabled peer did. And seek out resources proactively. Disability resources centers, peer mentors, professional association, as one professional advice, go to the resource center, even if you don't need it yet. Finally, participants urged disabled individuals to be bold advocates for themselves and for the system. Know your rights, know the policies, assess environments before committing to them, and recognize that while advocacy is vital, it also places an additional cognitive and emotional burden on individuals, and the burden that institutions must acknowledge and share. I'm moving to the next path. So the second path is allyship. The second path is for non-disabled allies, educators, supervisors, colleagues, and institutions. The message was consistent. Passive awareness is not enough. Active allyship is required. Language shapes reality. Language was a central theme. Instructors and leaders set the linguistic tone for an entire environment. As one student, Sally, made a request that I think will resonate with many of us here. Please, please don't start with what I can't do. I know what I can't do. Let's talk about what can I do? And when we come to the things that I can't, let's talk about how am I going to get around that. Participants also highlighted the power of ally disclosure. When professors or supervisors openly share their disabilities, it creates psychological safety and empowers others to do the same. From awareness to action, those 3 actionable principles emerge for allies. First, be curious, not cautious. Don't ignore the elephant in the room. Ask questions with compassion. Second, take the responsibility for your own education. Don't place the burden of teaching on disabled colleagues. And third, foster interdependence. Supportive culture is a collective responsibility. At the institutional level, participants called for proactive support. Don't wait for individuals to struggle. They call for holistic accommodations that see the whole person, not just a checklist. And they called for financial support that acknowledge the real added cost of disability. And they identified also a critical gap. There is often no neutral third party, no mediator to help navigate complex accommodations requested. This is a direct call to institutions here. That role needs to exist to support disabled students and clinicians. So the conclusion is, here is the heart of our argument. Path 1 empowers disabled individuals with tools for navigating and resilience, but the second path equips allies and institutions to build a genuinely inclusive environment. Neither path alone is sufficient. We need them both. When both paths are pursued simultaneously, the burden on disabled individuals is reduced and the system evolves. And that is what leads to genuine belonging, not just accessibility, but belonging. So the advice our participants shared is not just guidance, it is expert knowledge produced from lived experience. By creating structures that recognize and amplify this wisdom, we begin to repair epistemic injustice. And this benefits everyone. A health system that makes room for disabled students and professionals is more compassionate, more effective, and more responsive system for all the clients we serve. Our team also translated this research into accessible flyers for disabled individuals and allies, and it's available in this link, and you can also scan this barcode. I'll also put in the chat the paper, and I would like to also thank Laura and Tal, and this work also was mentored by Tal in my fellowship, and all of the great team that worked with us. Thank you so much. So now, Tal, we're back to you.
Okay. So just verifying that we have time for some questions.
I think we could keep it to 5 minutes if we can
Okay.
move on by 11.
Sound good. So there was some questions about maybe I'll ask a question before to the panel, and I wonder to all of you, all the panels, what is your greatest challenge as disabled health practitioner and researcher as it relates to what you just shared from your research findings? Anybody wants to start? Jump. It's a tough question, sorry.
Well, it is a tough question, and I think that's important. I think one of the greatest challenges, and we've all spoken to this, and is changing hearts. And Stacy spoke to this, and we have some approaches that we use, like theater, maybe a graphic novel, relationship, that's how we change hearts. But I would say that's one of the biggest challenges is the assumptions that people have, and thinking about some of what I shared around culture. And I think some of those assumptions are just so deeply embedded in the culture and health professions, in this imperative to be able-bodied, that capability imperative. And yeah, I would say that's one of the biggest challenges, is those culturally entrenched assumptions, and how do we change that, because that's something in someone's heart, not just their mind.
Thank
And that was
you.
Laura speaking.
Anyone else wants to comment, or I can read one of the questions from the...
I can answer. I think there are many challenges, and I think from my experience is the challenge of belonging through the journey, at different points of the journey, finding the way to belong with the needs and the challenges and the strength, and how to bring them into the professional path, and feeling that there's room for that, for doing things differently, especially in a different pace. The pace is also an issue in health professions. And like I said, also with the disclosure journey, which is Stacy also talked about it, the prices of disclosing, but also the benefits and the importance. And I think that the disclosure journey is also, it's a lifelong journey, and it changes all the time, and it has different demands, and it's something to learn how to do at every step and of this life journey.
Thank you so much, everyone, for this fantastic session. Sorry for the technical difficulties, but we'll be able to answer some more questions for our fantastic speakers in the Slido.